Hi, everyone. My name's Jordana Saunders. I am the CEO and founder of Trauma Recovery Services of Arizona. We are a very small but mighty behavioral health service clinic. We work in the state of Arizona. Our focus is specifically working with marginalized and underserved communities. So we work a lot with BIPOC folks, Indigenous folks, and also veterans. So some of the questions that you have about that, I can certainly answer, and also speak a little bit about our dynamic business model and some of the needs that we've identified in some semi-creative, high-risk, moderate reward, initiatives that we've used to kind of fund services. So.
Hi, everyone. I'm Dr. Sierra Gromoff. I'm co-founder and CEO of Kismet Health. Kismet Health is the first pediatric telehealth technology. We are very unique in that we're also the first biometrically driven diagnostic tool to give live time interventions, results, and clinical outcomes to really help enable providers in real time, whether that be a community health worker or a social worker who doesn't have quite the skill set to really do those deep diagnostics, to really enable them to give the right treatment at the right time. A little bit about my background. I am Aleut Tlingit enrolled member. I grew up in rural Alaska. The reason this is so personal to me is because telehealth today is literally the only option that most tribes can access care. It takes about 8 hours from Anchorage to get to my village. There's no children's hospital in Alaska. The closest hospital is Seattle. And we often medevac kids, either for behavioral health concerns or major medical concerns. So how we really think about technology is like not only children have to engage for it to work. Zoom was built for adults in workspaces, not healthcare. Secondly, low tech literacy. My grandma could not do a FaceTime call to save her life. And that's so much of the population, especially in rural, underserved, BIPOC communities. They don't have tech literacy. And interestingly enough, building for a 3-year-old is actually building for an 80-year-old. So thanks so much.
Hi, my name is Alana Berkowitz. I'm one of 2 general partners at Springbank Collective. We're an early stage venture capital fund based in New York. Our focus is what we describe as the missing infrastructure for working women and families. So we invest across 3 thematic areas: the future of work, the new care economy with a lot of focus on the caregiving experience, and household consumer, which I can talk all about later. But both in my angel investment and venture portfolio, I've invested across a bunch of different areas in telehealth, including Gesundheit, including women's health, family mental health, trans and non-binary healthcare, and a number of other spaces. I came from a public policy background in Obama land, so also have lots of thoughts around what is broken in the regulatory landscape to enable a sort of hybrid clicks and mortar universe. And I'm excited for us to just go wild and self-moderate.
That's why we have our phones out. Didn't memorize all the questions, so bear with us. We're not texting or on Snapchat.
Well.
Oh, I mean, maybe. No, I'm kidding.
I'm watching Reels.
Yeah.
I'm just kidding.
Well, should we start with the first one, ladies? Let's jump in. So I'll ask the question, and then someone else can respond. I'll give my response. Actually, I just moved the Google Doc. Dang it. Okay. Number 1, what are the most pressing challenges in healthcare access that telehealth is currently addressing? You want to start?
Sure. Yeah, I'll jump in. So just to kind of piggyback off of what you were talking about in your introduction, I also was born and raised on the Navajo Reservation in New Mexico, quite rural. Honestly, didn't even know what psychology was when I was growing up. It was not a thing. And so fast forward to, when we had COVID and a lot of practitioners jumped from in-person, myself included. So really, I think the issue that I see a lot is accessibility, and I'm not just talking about accessibility from the technology side, but also accessibility in terms of cultural and for the work that we do, trauma-informed services, because we're working with communities that have been deeply impacted by, I would say, things like genocide, slavery, to name the things that often we don't name when we're talking about how people have access to healthcare, and those things really deeply impact accessibility. So if we're looking at affordability for certain modules of telehealth, in my area, in my industry, we specialize in a kind of therapy called EMDR. It's eye movement desensitization reprocessing. I see some people nodding, right? Amazing modality. I didn't know about it. I actually got trained working in a tribal community, and now that is one of our prime specialties. One of the reasons I love it is it's culturally appropriate. It's neurologically based. It takes the whole symptom, the whole body. It takes everything into account, and it sort of turns trauma on its head. So it's a really innovative and practical way to treat long-standing issues. And so for me, telehealth helps us bridge those communities that don't have access to services. And so that's really the big piece for me, and the work that I do is that accessibility and looking at it across the spectrum. So, we deliver services at low or no costs, as well as most of our funding is through third parties, so commercial insurance, Medicaid, Medicare, but we do fundraising, and we also have a fiscal sponsor. So we just kind of hit that whole spectrum to try to get as many people access to services as we can.
I can piggyback. I think, there's a couple of factors, as discussed, access, but I think there's some other pieces as well around expertise, safety and confidentiality, and efficiency, which is obviously part of this access story. And, just as a little bit of context setting, for instance, 'cause I think all of us are very interested in family mental health. In almost 75% of all counties in the United States of America, there are 0 child psychiatrists. Not a couple, there are 0. And then, those are one of those cases where, of course, like a tele approach is going to be a necessary kind of part of the solution. And frankly, I think it makes sense. I think one of the things that we saw during COVID, I think, on the one hand, it did vastly accelerate the adoption of telemedicine, but there's still a cap on it, because the truth is, for folks who do have access to brick and mortar in many specialties, that is often the preference. I think mental health is one that is uniquely well suited to this space. And then on the safety and confidentiality ends, obviously the fall of Dobbs was, or the fall of Roe with Dobbs, was devastating for women's health on a number of dimensions. But for instance, telehealth has been a really important part of the story. So 4 years ago, 4% of abortions were telehealth enabled. Now it's 20% 4 years later. So those are medication abortions, right, where people are using these platforms to access those medications in a timely fashion. In that case, there's both an accessibility issue and there's a confidentiality and privacy issue, right, of women who want to access care in a dignified way, with access to providers who are going to be understanding of where they're at. And similarly, we were one of the first investors in a company called Plume, which is now the largest provider of trans healthcare in the world. And there are very few doctors who do gender-affirming care. There are many states where folks feel in danger publicly seeking it out. And obviously being able to seek out some of that care, in a kind of telecontext, obviously, I think creates a lot of psychological safety and also, frankly, gives you access to a lot of different kinds of experts. And the last thing I'll say, too, is in addition to the sort of the role context, we're also in a rapidly aging moment, which is something our fund thinks a lot about. So 10,000 folks turn 65 every day. Obviously, there's an increasing trend towards wanting to age in place at home, but also senior care facilities are still a big part of the equation. And almost none of them can afford to have on-site specialists. So we're seeing a lot of use for telehealth in a aging community context, right, where they might have a couple of nurse practitioners or a geriatrician or a primary care physician on site. But for instance, they might have someone who has a really urgent cardiac issue or a very specific, issue with their knee, where those kind of specialists would be, would explode the sort of financial health of these communities. And that's a place where we've also been seeing a lot of layering in of tele. Yeah,
I mean, I think, I'm coming from a unique perspective. I've almost exclusively worked in tribal health and for Medi-Cal. And 6 years ago, I actually developed and deployed Medi-Cal's first telehealth program. And you would think in the Bay Area, it's a center of innovation, of accessibility. Parents, I had the novel idea of asking my patients, why didn't you come into session? What was the barrier? I can't afford the bridge toll. I can't afford gas. I'm not here legally. I don't want to get stopped by CHIP. And so that's what made me be like, okay, this problem that I grew up with is happening here in Oakland. Like, let's figure it out. And it was horrible to try to engage a 3-year-old on Skype at the time. I eventually moved to Zoom, but everything about it completely disabled the kid from doing that. I couldn't do the interventions. I couldn't catch their biometrics. I couldn't track their eyes. But still, it was a lifeline, and it was still better than them not coming in at all. So I think the future is honestly hybrid. I don't think it's exclusively one or the other, but we need all the tools that we can have access to make sure that kids, families, mothers, everybody is able to get the care when and how they want it and where they need it, whether that be, in a school environment. We're very flexible in how our technology is being used. We're in primary care, we're in school settings, we're in tribal health clinics, because it's wherever the kids are getting care. And, the safety and confidentiality thing, I think it's a huge thing also for, a lot of people want to do group therapy with kids, which is an incredibly effective tool. But there's a lot of teens I've worked with that want they want to be anonymous within a group environment. So we actually created avatars so that they can change their face, or like a Snapchat filter, and be able to show up in whatever way, like whether they don't want their classmate to know they're going through XYZ, or their body doesn't match their gender identity. And then suddenly they're able to be whatever version of themselves they want to be. And that's like a way that we feel makes it more accessible to kids. I've thought long and hard about how do you make telehealth secure if you've got 20 family members in a 2-bedroom house. I haven't cracked that. If anyone has ideas, please come up to me, because I've spent an ungodly amount of time trying to think about this. But one of the things that we did do to try to solve this is we worked out a partnership with Starlink. So kids that had no space in their physical home, or the internet didn't reach, or they didn't have internet, because what good is telehealth without internet? Doesn't work. But a few families that we have worked with, we got them Starlink, and they'd go and sit in the car and do their telehealth, so that they got a sense of 4 walls and privacy. But that's as close as I've gotten to solving that problem. Do you want to read the next question?
Sure. So the next question is, how do each of you, investor, entrepreneur, technologists, contribute to solving these challenges, and what are the biggest obstacles you face?
I'll start. I feel weird because I just was talking, but no one wants to invest in pediatrics. You will hear all the stats, and more money has gone to pediatrics than it ever has before, but the ROI, the KPIs do not align with venture. I cannot tell you the disturbing conversations I've had with some of the leaders in health tech, the main investors in health tech, that say pediatric population is too small. That's too small of a population to specialize in. And it's not my problem. Insurers go, it's government's problem. Government is like, we're trying to solve this slowly. And innovation goes, this is a Medicaid problem. So it's actually this quietly compounded situation when I'm pitching a completely innovative, never been done before technology in a population that doesn't drive a lot of money, is not gross margins, and people don't care that they're 100% of our future. People don't, my first visions of pitch decks were showing all the KPIs of early intervention, that actually you're going to save so much money if you treat them while they're 2 years old and having the issue versus 17 and in and out of inpatient rehab. I actually did a financial time study of a patient I had that over $3 million worth of care was spent on this kiddo. And he came in to be evaluated me before being sent to long-term out-of-state residential. I was with him for 20 minutes, and I was like, wow, I've never seen a facial tic like that. That's not from psych meds. This is odd. I took a 20-second video clip on my phone with consent and assent from his family. I sent it to our county neurologist, and I said, hey, take a peek at this. I don't know what this is. This is weird. He called me at 9 p.m. that night, and he's like, get him in my office. It's a brain tumor. Sutter, Stanford, UCSF, and I think one other hospital all had seen him. No one once consulted with a neurologist. No one once. I did a med review, I did a chart review, only 3 times mentioned odd facial tic. When you think about how telehealth actually has, or video has the capabilities to take a 20-second clip, and for that provider just to be like, I don't know what's going on. Ted in neurology, what do you think? John, like if we really want to move towards collaborative care, the only way to do this is thinking about technology in that kind of way, or value-based care. So I'd say my biggest hurdles are convincing kind of the powers that be, and paying to integrate with hospital systems. That's probably our biggest expense besides AI engineers, is integrating into Epic. That was a huge push, but it's the only way to play in healthcare. So when we think about like people who have innovative ideas or like incredible ways to solve problems, you're going up against Goliath constantly.
Yeah, I mean, across healthcare, I think there's always these challenges of incentives and legacy systems. And maybe on the incentives piece first, to your point about, the unbelievable societal value in early intervention, the average tenure of someone on a health plan is 18 months or less. They churn constantly. So that means that if you're a health plan, and I go to you, and this is in pediatrics, this is in things like, all sorts of preventative care. If I go to you and say, if you pay for this course of, preventative care today, you're going to save $100,000 in medical costs, when they age into the Medicare population. I just made that up, obviously. But they won't be on your plan anymore in all likelihood. And so a lot of those plans are saying, like, I want to see year-on-year ROI in 12 months. And, like, that's very hard to do. And so it's no surprise. I've been pitched over a dozen AI for revenue cycle management. It's a very sexy space. I've in the last year, in part because that is a place where people in the system can make a lot of money. At the end of the day in healthcare, though I ultimately think we will end up with some very enormous direct-to-consumer healthcare companies that will look very different than what we currently consider healthcare in the next 5 to 10 years. Right now, like, the largest payers are health plans and health systems. And you have to be very baked into their set of incentives, which, sometimes are aligned with health and well-being and sometimes are not. And I think that so I think that is part of the challenge, and that is obviously part of the challenge that then for those of us who sit in the venture capital seat, and I run a non-concessionary market rate return fund, there are certain specialty care is almost always more expensive than things like primary care and things like pediatrics, and easier to build the kind of businesses that I think sort of appeal to the investors that we have inside of our funds. And then, I think one other thing too is this margins issue. I think that for folks who are used to investing in software, healthcare is always going to have many fundamentally, deeply, and profoundly human elements, and that is not going to go away. And that means that what great margins look like in a digitally enabled service business do not look like what they look like at Figma or Slack or whatever. And obviously, I think increasingly there's lots of awesome healthcare investors who get that. But I think thinking through that transition, and obviously, many of us, you're already integrating AI very much into your product. We do a decent amount of AI investing, and we are seeing already some margins improvement in core care, in primary care, in mental health, from AI integrations, and some of it is not like complete rocket science. It's more stuff like ambient scribes, so that the amount of time, for instance, that a child psychiatrist might spend taking notes and writing down care plans after a session, like, can sort of easily be automated. And if that lets them do one more session a day, or frankly just feel less burnt out, that is all to the good. But I think that sort of some of these margin issues and some of these issues of really understanding what are the financial incentives driving the primary purchasers of healthcare in the system now, limit our imagination in terms of the solution set sometimes.
Yes. Yes to all of those things.
Mic drop.
Mic drop, yeah. I think that then filters into what we see on my end with the staffing shortages. Like burnout is a huge issue in my industry, as well as getting people qualified to actually apply for positions that we have. Like right now I have a vacancy that, I'm not getting a lot of applicants for. And it's probably gonna take me a while to find somebody. And what I found is most effective is actually training people towards that. But in our industry, there's a lot of pay inequity. So again, when you're talking about the margins, right? So the drivers, when it trickles back down to the provider arena, that's where we're hitting these walls of how do we pay these people, a living wage. These are incredibly educated folks. They're incredibly specialized, and yet we treat them as if they're disposable because our values are not, humanity. Our values are capitalism. It's like, how much money can we make from this person right now in this minute versus what's going to happen in 10 years if I don't address the problem right now. And so I think that's a lot of what I run up against as a small business owner, is like thinking long term versus immediate and having those conversations. And so for me, what that then leads to is obviously frustration in having conversations with people about that. And even here, people have been like, oh, are you're seeking investment? And my short answer is usually not really, because I feel like, it's not values aligned. Again, I'm looking at healthcare issues in the future. I'm working with these communities that have issues with digital literacy. Yeah, our primary method is telehealth, but we do go into communities and meet them where they are and try to cross work to say what's going to make the best impact, the most impact. And that requires time and relationships. And that's not something that a third-party payer is going to reimburse us for. But it is something that's going to later equal better healthcare outcomes for those people that then engage in those programs that we're building collaboratively. And so there's a lot of that doesn't get captured, I think, when you're talking about health equity and you're talking about telehealth. And to speak a little bit to what you said about hybrid, yeah, we're primarily a telehealth company, but we do hybrid services. I was just in a very, very rural tribe, and I even have to sometimes catch myself and say, okay, what's the infrastructure really look like? And, Indian Health Service reached out to me and said, hey, we'd love to send these referrals over. We have this, this, and this. Your company would be great. And I was like, sure, let's collaborate. Let's work through it. We were getting referrals, but we were having difficulty reaching the patients. And they said, we really want you to come to the community so that you can see what we're dealing with. And I'm like, what's going on? Like, you guys have phones there, you've got computers, right? You have all of the infrastructure that we need to get folks engaged. Well, I went there, in the bottom of the Grand Canyon, and surprise, surprise, internet's unreliable. Phones don't work in certain parts of the canyon, And so it really gave me that fresh perspective of saying, yes, we have this, but there's intermittent access. So how do we reach these people? So now we're working on a hybrid program where someone from my team will go down. And, it's a really rural area. It's 8 miles. You have to hike. I ended up having to hike out, which was exciting and also kind of overwhelming. Like, wait a minute, I'm hiking out of the canyon. But I think that's the thing, right? Is if you're going to be in healthcare, you have to understand the populations that you're treating, and you have to have a vested interest and have values alignment with those communities. Because if you don't, you're not going to meet them where they are, and you're not going to innovate towards what you were saying, like the 3-year-old and the 80-year-old. And I mean, I think that's really where we kind of connect.
Could I add? Oh, sorry.
Oh, go.
Oh, I was just going to say on this staffing conversation, because, if you look at functionally all of the sort of highest shortage careers in the United States right now, they're basically all in healthcare and caregiving. Unfortunately, some of these jobs are not very good jobs. So one is sort of the clarity of perspective of, for instance, like there's an unbelievable shortage in home health care aides, right? There's a reason why you're seeing, hundreds of thousands of older folks on the rolls, like waiting for home health care aides. You can, in many cases, be making more money at Starbucks or Chipotle, and you don't have to like lift someone by yourself and tend to a bedsore. It is very different work. And though I have been on the receiving end of many a pitch saying we will sprinkle AI magic and then it's going to be amazing in home health care, the truth is, in many cases, it may be that, for instance, until Medicaid and Medicare increase the reimbursement floor functionally for home and community-based services, or until immigration laws, if there's changed considerably, there's still going to be kind of a care shortage, and I think we need to acknowledge what those kinds of jobs are, and are there efforts across different sectors that can make those jobs better jobs with greater dignity. And then on the other side too is also, for every one solar installer the United States is going to need over the next 20 years, we're going to need 20 nurses. So I think we talk a lot about the green jobs shortage, which I'm also very interested in, but the health and caregiving job shortage is bananas. And there's a couple of ways of thinking about it. One, to this sort of where can AI play a role, just because people ask for specific examples. Just 2 examples, one of a company I did invest in, one of a company that I kicked myself for not investing in. But on the first, I've been very interested around areas of the workforce where women predominate, where I believe the software stack has been under-innovated. So obviously nursing is chief amongst them. For folks who live for senior nursing facilities and things like that, they are reliant on Medicare payments. And guys, I'm going to go to a sexy space again. Medicare documentation audit and compliance is currently done by nurses. Mostly it takes a ton of time. They do not enjoy it. They want to be doing direct patient care. It is painstaking. And it leads to $40 billion per year in delayed or stopped payments for Medicare. The Centers for Medicare and Medicaid are obviously the largest providers or payers of healthcare in the United States, who need to audit functionally like 1 billion touch points of healthcare every year, which we want to happen because it's our taxpayer money. Anywho, so, we were very interested in saying wow, this seems like a really big bottleneck in both people getting paid and in nurses being exhausted and not having as much time for patient care. So we invested in a company called GuardDoc, actually started by a nurse, built for nurses, where she teamed up with a bunch of natural language processing engineers and sort of automated herself after years of doing this very painstaking work. And typically for each senior living facility or specialized nursing facility where it's been implemented, nurses are saving 25% of their time that was previously spent unraveling these funky records. So that's one example where the technology is not going to be a miracle, but there are areas where you can get a little bit of leverage in the middle of this labor crisis. Or another example, I think all health practitioners want to operate at the top of their license, right? Being able to do their highest and best work, and we have not always made that very easy. So I'll use a fertility example because I'm very passionate about women's health and reproductive health. Currently, one of the many bottlenecks in the reproductive health care system, which is unbelievably expensive for anyone who has undergone fertility treatments of any kind, and statistically that is probably many of us in this room, there are all of 1,300 reproductive endocrinologists in the United States. There are more than 10x that many gynecologists. I bring this up because many reproductive endocrinologists are making over $1 million a year. They are wildly in demand. Clinics are flying them around. I know some REs who will work in 3 different states in the course of one day. That's a major bottleneck. And at the same time, you have folks, especially folks living in rural areas, where if you are undergoing fertility care, even to get basic scans and blood work, you might be driving 1 to 3 hours just to get that. So there's a number of companies now that are in this space of saying here it is, OB-GYNs are one of the least well-paid specialties
in the medical world, but there's many more of them. What if they were doing parts of the fertility journey, like these scans, like blood work, that frankly, of course they can be doing with just like the slightest bit of extra training. Now these folks can be cared for in community with folks they already know. These OB-GYN clinics that, especially because of insurance prices, are running on a super thin margin, can be making a little bit of extra money. Frankly, the REs who are clearing over $1 million a year are thrilled because they can take on more cases where they're doing this sort of harder, like more technically complex portions of the fertility process. So anyway, those are just two very different examples of places where I've seen interesting business models that kind of work within the incentives that we have today, which I know are very frustrating incentives, but are creating structures that I do think, create room for healthcare professionals to, earn additional revenue, have a more dignified work life.
Yeah, that's a lot of what we're doing at Kismet, because 60% of pediatricians are prescribing psych meds with not one single lick of psychiatry training. And I will tell you, ADHD, PTSD, and anxiety look almost identical in a 3-year-old, 5-year-old, 6-year-old. It's really not until they're able to really decipher where is the inattention or kind of the impulsivity coming from myself. Anyway, this is not a talk about ADHD, but giving Adderall improperly to either one of those subcases, anxiety, causes an active dissociative state. It causes kids to repress their feelings and go on autopilot. I get why pediatricians are doing this. The number one thing that we get asked for in our technology is, when are you rolling out your co-pilot? Because we're collecting all this biometric data with ethical and consent, eye tracking, respiratory rate, heart rate variability, eye tracking, live. This is live currently, lifetime vital signs and vocal biomarkers. We triangulate all of that against NIH data that has shown, like, this is the eye tracking for ADHD, this is the eye tracking for autism, and basically come up with a correlation. And then that is to also enable these primary care physicians to be like, okay, 70% likely it's ADHD. Okay, let's take the shot with Adderall. Whereas that's right there enabling them to provide the best care. They're still able to make that decision, because the thing that scares me the most, and the first suicide from a chatbot just happened last week, we should not be thinking that AI needs to be handling mental health. That is like, no. I want to be the guardrails on bowling. I want to get doctors down the lane. I'm like, get you to hit the right pins and in the ballpark, like, it's not going to be exact. I will say there's an incredible company called Cognoa by Dr. Sharif that he has nailed it in autism. Like, if anyone wants to hear about that, that's amazing. But the thing that I really see is, because there are no pediatric data sets, because care is so fractured, you can get EMR data, but no pediatric, like, biometric data sets. And this is where we're going to be able to enable those community health workers to know if they're sitting with a mom who's like, oh my God, Jimmy bedwet again, and I'm like at my wit's end, what do I do? Unless you're a super seasoned clinician, you can't think right on the spot, like, okay, bedwetting, best standard practice, 3-year-old, developmentally appropriate. Okay, let's try, like, are you doing before bedtime, 10-minute pees? Are you stopping water at 6 p.m.? Like, memorizing that stuff takes time, but a community health worker is absolutely, a parent coach is absolutely able to deliver these life-changing interventions. And so through ambient listening, and we've proven this, it pops up that intervention. It knows that Jimmy is a developmentally normal 3-year-old white boy, so it pushes those interventions, and that community health worker right then and there is able to deliver best-in-class interventions. Because, yeah, the last stat I'll say that's really disturbing to me is 30% of pediatric residency sites this year were unfilled because no one applied. No one applied. We are not going to have pediatricians at this rate because it's twice the work and half the pay, and 60% of kids are on Medicaid. It's a horrible ROI to go to med school and go into peds. And I just think we have to get smarter and think stronger about their time and how to really do this, because, like, I really believe that we're going to be in such a dire, horrible state if we don't do this kind of thing. And I think it helps Indigenous people the most, because IHS doesn't have one single child psychologist or psychiatrist in the entire agency. Not one.
Could can I ask you guys a question? Since we don't have a moderator, let's just get weird. No, I'm just kidding. To this point, you know, I think obviously we've reflected on a whole bunch of these advantages around telehealth, and then there's really this outstanding question of trust, right? You know, there's so many reasons why promotores de salud have like a lot more community trust than folks who might have, you know, a medical degree in some relevant specialty. And, you know, and I think this is something we see clearly in the data. So, you know, over 1/3 of folks 65 and over say they, quote, like, don't feel ready for telehealth. And when you look at those numbers, I think it says multiple things. Part of it is the technology literacy, but part of it is saying, like, you know, I'm used to my PCP, who maybe is only okay, and there's like a trillion-week wait, but it's a thing I'm used to. I'm comfortable if there's trust. And I'm curious what you guys have seen work in a either like hybrid or tele-only modality that is trust building and sort of creative on that dimension.
I would say the fact that we have a consent and assent module for as young as 3 years old, that every provider that uses Kismet, it knows like the age, and it says, hey, like the protocol for a 3-year-old goes, hey, we're recording this, and it's because data is like a little tiny piece of you, and by you giving, like letting me have that data, I'm gonna be able to help kids like you a lot better. But you can tell me no, and we won't record that. It's transparency. I would say Indigenous people don't trust healthcare. I barely trust healthcare. I mean, and I am a healthcare provider, and I still have had really bad experiences. I mean, I was trying to get my wisdom teeth out, and the dentist was like, you're native. I can't give you laughing gas. You'll get addicted. I was like, you think I'm going to run out of this clinic with the tank? Like, go, like, huff? I was like, bro, you can order this online. Like, this is not, you're in the wrong lane. But that feeling and not trusting, being transparent, being like, I know, I don't know, I say like, hey, this is your choice. It's your body. It's your data. Please give me a chance. And for teens, because teens are the funniest in a lot of ways, and a lot of negotiations about the stuff they want to tell me but are afraid they can't tell me because a parent, like that juxtaposition is actually quite interesting, that we Kismet users in California, the parents can't access the teens' data, any sensitive data, mental health, sexual stuff, HIV, AIDS status stuff. We go through that, so we build the trust in that way. And then I school them on Fortnite, so like they respect me.
Yeah, that's a great question. I think for me, in the work that I do, it's again related to building relationships. So the example I gave earlier about going to the tribe, you know, in a rural area, whether it's tribes, I mean, veterans, really, I think that's where the hybrid piece is. Like, we're talking about telehealth, but there has to be a face. I mean, there has to be a relationship. There has to be something there that is a bigger driver, because people are distressed. You know, by the time they're coming to healthcare providers, usually it's past the point of when they needed to come see us. And so we have to provide some certainty and some safety. And a lot of times, like, I'm a psychotherapist, so the foundation of our work is relationships, right? Regardless of the intervention that we use, that's the thing that always comes back, is the relationship is the fundamental driver of change. And so, and in Indigenous communities, that's also a fundamental driver. We have to trust you, and we have to believe that what you're telling us is not going to harm us. And we do that by giving you small little pieces of things over time. We're not immediately going to trust you. When, like, the first half day I was in the community, there were flyers up all over the community that I was coming down. I had my picture on the flyer. I was like, oh yeah, I have this many years of experience, you know, all the things. I like my cats, you know, being a human being, right? And I just walked around the community, and I was like, hey, what's going on, you know? And at first they were like, eh. And then there was my pilot person, the one brave person that was like, I'm going to come see what this lady's about. Is she okay? Is she safe? And then after that, more people were willing to come. Hey, my cousin needs to come see you. Hey, can you come talk to this person? Hey, over here. Hey, you're the counselor lady. You know, I'm going to get my lunch and I'm like, yeah, that's me. I'm the counselor lady. I'm here for this, you know, and it takes that, you know. I got an email today from the social worker saying, hey, they're asking about you. When are you coming back? You know, but they are willing to take a chance on me, and then they're willing to take a chance with one of my providers. And the thing I tell them is, like, you have choice, you have agency. Going back to that, you have a choice. If you don't fit with that person, please tell us. Like, we're not going to be offended. We're not going to be hurt. And I think that's really one of the fundamental differences of, like, meeting people where they are. Like, we're not trying to just push something on you quickly and get you in and get you out. We're trying to figure out what's happening and build a relationship with you, because that's really going to be the biggest driver of whether you trust us and whether you're willing to tell us what you're really coming in for.
Yeah, and just to
Oh yeah, we got.
oh,
flagged.
cool. Oh, just to also follow up on that, I do think one of, like, the advantages potentially with telehealth, you know, to this sort of provider trust and culturally competent care extent is, you know, for instance, you may say, like, I'm a combat veteran suffering from PTSD, and I would like to see a therapist who is a veteran. And given how long the wait lists are for any therapist at this point, it may be that, like, the fastest way to see someone who you believe can, you know, speak to your experience will be going to a tele-platform, because obviously you're just going to be able to access, like, a far wider group of providers. So I've seen that as sort of part of this trust building when there's the opportunity for matching for more culturally competent care. And then on the younger side, one thing I've just been curious about, I mean, you were joking about Snapchat, and I promise none of us have been Snapchatting while we're up here, but, you know, there have been a couple of companies, like things like Hero Journey Club and other things. So Hero Journey Club essentially is sort of embedding, like, avatar-based group therapy while you're inside of the video games you're already playing, that teens are already playing. And, you know, I think we're just at the beginning of experimenting with, you know, what are the, you know, the sort of online third spaces that I think have become, like, the place where a lot of the younger people in our lives are spending, frankly, the majority of their free time. And I think figuring out how care, whether sort of truly clinical but probably more subclinical, kind of integrates into those conversations and respects that, like, I know a lot of younger people who just want to text message providers. Like, they don't actually want to get, like, they either want to have an in-person visit or they want a text message, and they definitely don't want you to call them on the phone. You know, or certain things like that of thinking about, like, how do we build next-gen platforms that are a little more attuned to, like, where people are already spending time and are building thoughtfully to actually sometimes spend time in those places, like within video game environments, or at least sort of build user experiences that are responsive to the kinds of consumer experiences that people have come to expect on their phones, instead of feeling like, I'm sure we've all had the same experience using, like, a HIPAA compliant video app and feeling like, why is this the worst software experience I've had in my entire life?
Yes, I cannot emphasize that enough. You got to speak everyone's language. If you're a kid, it's play. It's being able to meet where they are at. If it's someone who doesn't know, if elderly and they don't know how to use tech, it's actually eliminating that barrier by either doing it with them or making it seamless. We naturally had a dementia clinic sign up, and they're like, we just love that you can draw and do, like, your colors are soothing. And I was like, great, I'm not having to change the product and you're paying me, so that's amazing. But I was like, wow, it does make a lot of sense that controlling the environment for them makes that stress. Where we actually test all of our stuff on real kids, and I was at a children's conference with kids. It's my favorite conference, because the kids actually are doing most of the speaking. And a kid that was in one of our research groups ran up to me and was like, do you have 10 minutes to talk? I'm like, oh yeah, of course. She was like, I was in your second Kismet group, and I just really I do not like that you removed the end call button from me. I want to decide when to hang up. If I want to hang up, I want to be able to hang up. I was like, yes, that is so true. I was like, totally get that. So we made it now age-based. So, like, the call, because, like, I've been hung up on 100,000 times. I cannot tell you that the red is neurologically attractive on the Zoom, and it's like a 3-year-old's like, boop, boop, group, like have spent more time being IT support than a clinician just in that one effing feature on Zoom. And I was like, they need agency. So it's like, again, it's meeting them where they are, it's speaking the language, and not thinking actually, you're going to get this, like the thing that boggles me about a lot of tech, quite frankly, like Brightline, Little Otter, et cetera, they don't run anything by the kids. And the kids, you need a sticky client, but if you do listen, you have the stickiest client and you have repeat, and it just makes so much sense. It's the principles of human design. Yet in health tech, it's like we're not okay with human design. But I feel like it's changing. At least we're changing it, but I can't speak for the rest of the groups.
I have a stack of questions here. Does anyone else, before we like rip through them, have if there's something that's been weighing on your soul, please deliver it and we'll read it.
Joey.
So I'll just go through them.
Yeah.
What are 1 to 2 practices you've seen in delivering telehealth effectively in schools with middle and high school students?
Well, being flexible about if they need to reschedule because of societal or social pressures. The shame response, like therapy is getting cool, it's normalized, there's a lot more trend in that direction, I will say. But I have found, again, talking to kids, being able to be flexible about timing or just being less rigid is the deal breaker for whether or not some of them get care, especially kids with super strong shame responses. And making it, fit, like giving them more agency, especially in high schoolers. And kind of opening up, being like, name it to tame it is what I say. Being like, hey, I know you, it was prom last week, or just really using the telehealth to show that I'm also tracking them and I know what's going on in their real life. That's not a tech solution, that's more of a clinical feedback. But yeah. Yeah. Yes. So we either work with the health counselor office, or if they're very remote, they don't have that setting, it's whatever room is empty. And then depending on, one of the things we do, because I charge health tech, venture-backed health tech companies is a very different price structure than what we try not to charge tribal health clinics. We actually try to get funding and grants from non-dilutive or family offices so that they can use it fully for free. And so sometimes, if they don't have a computer, we'll send a tablet with, all set up. And then basically I work with whoever the front desk person is to make sure that we're in sync with our care coordinator so that they can get just a room that's empty. We haven't ever had it, and granted, we're only in Canada and the US. I think it gets much different when you look at schoolhouses in other countries that K through 6 is in one room. But in those instances, they can find some type of room or space to use for that time period. This is where probabilities come into play. Having those type of diagnostic features wouldn't be as strongly registering if they're not clinical. It'd be subclinical or not. But clinically speaking, and I haven't solved this, we have some things to bring parents in session. My practice and what I believe, and what, again, I haven't seen anyone really solve this, is you gotta do whole family therapy. Because if mom's not good, baby's not good. But being able to equip a parent who's been trying hard, but this kid is just I've just assessed so many kids that I've seen the ADHD 2-year-old where they don't sleep for 3 days straight. They're trying they're trying everything, and the parent's what is, something's off. Autism is another one that, especially minority kids, do not get diagnosed with. They get diagnosed with conduct disorders or kind of other racist problematic entities where I like to say this, it's driven in biometrics, it's not driven in these assessments that were made by insurers and white little boys. the ADOS was mostly tested on white little male boys, and that's why black boys do not get flagged by the ADOS as likely. But biometric is a way to curtail bias and then show the receipts, because any doctor can click and be like, what is our data driving from? Because that, I think, is a huge problem, and why, on average, when I was at Medi-Cal, and this is I hope no one in here is at Medi-Cal, because this is a disturbing stat. On average, the kids, by the time they got to me, because I was oftentimes the only doctor in the county, they would have 5 different diagnoses. Even ones that literally, I've seen kids diagnosed with schizophrenia that you cannot, if you go in the DSM, you can't diagnose schizophrenia in a 5-year-old. But they're hearing voices. They will just check off stuff. And that's kind of the problem, is because then they're getting labeled improperly and they're having a litany of just all wrong stuff. But because Medi-Cal doesn't have the resources, ability, or wherewithal to really center doctors as the first line of defense, because there's a high need, not enough providers, this can drive to prevent that and then get the most marginalized people, at least in the ballpark of accuracy. As the data grows and grows, and as we get bigger and we're in more spaces, we will move towards FDA approval to actually be a diagnostic and a billable. But we've been talking to the FDA, and we kind of have to titrate it out this way. But I see that as a provider as one of the biggest issues was just the wrong labeling, wrong interventions, especially in black and brown kids.
Is it okay? I think I see that we only have a couple minutes. I'm going to do a last question. Also, by the way, on the school, if there's specific school resource questions, I'm happy also to talk more afterwards outside of the mental health context around like some of the healthcare sort of hybrid providers. Some of it's also dependent on whether the school has the resources to have an in-school nurse who is like partially care managing. But and just one other note before we ask this very nice last question that someone wrote in is, to this point about whole family care, because there's been a lot of focus on children up here. I also want to sort of double click on the mothers of those children. Part of the beyond the fact that whole family mental health care just works better, the truth is there are a lot of moms, for instance, like look at the rates of mothers who skip their 6-week postpartum appointment. It's not low. And those are a lot of times moms who would never skip their kids' pediatrics appointment. And so increasingly we're seeing a lot of folks thinking about, how do we get women to actually get the care, to not skip their own care? And sometimes this sort of, it's put within the context of their children's mental health conversation. All of a sudden you see higher rates of adherence, or we've seen a couple of companies where they're actually trying to do well women visits at their child's pediatric visit to sort of, make sure that women's needs are being attended to as well. I'm going to ask this last question to our esteemed panelists. I'm sorry, it wasn't actually the last question, but we ran out of time. This is maybe why you shouldn't self-moderate. We're all learning important questions, or important lessons.
We all have soapboxes.
Yeah. This session has been awesome and the most sad, frustrating, and overwhelming I've been in. What is keeping you going and optimistic?
Wow. That is what's keeping me going and optimistic. It is sad, frustrating, and overwhelming, but I don't think it has to be that way. I feel like it doesn't have to be that way. And I was having a conversation earlier with someone, and I said, in my community, we're only 2 generations away from boarding school, but look how far we've come. And that's the thing, I guess, hope. Look how far we've come.
Talking to the kids that use Kismet is like what I do, and I sometimes make the engineers do when they're stuck on a problem, or like recently we had to rebuild some back-end thingamajigger, and they had to work the weekend because we had a sharp deadline, and I sent the written things that a kid, and a picture the kid drew of like, and I was like, yeah, like we're making it better for them. They feel seen, and like, not to be, I don't think I'm gonna like cure cancer or anything, but I honestly believe trying to move the needle in biometrics and trying to solve it, I feel very driven by that. I feel like that's an equitable way. It's scalable, it's technology, and I trust myself and my entire team so deeply that I feel energized by it, and I think it's because I'm not fundraising right now too. But when I get to have that real moment of reminding why I do this and seeing the real kids' feedback, it keeps me going.
My answer is the first half will be cheesy as hell, but bear with. I started my career in policy and politics, and I always feel like one of the things that's the most similar between political campaign people and startup people who are both completely insane in some similar in some different ways is like, you don't bother to do it if you don't think there's at least a slim chance that tomorrow might be better than today. Like, you just would not bother to walk into either of those places. So I get to spend all of my time with kind of insane people who truly believe that. I think too, like, this was not a tech bio panel, but there are some unbelievable, like, incredibly cutting edge, interesting things happening around, AI drug development, around the sort of gut-brain axis, around some like really interesting drug developments there. It just sort of feels like every day there's like something interesting and surprising, and even like in the context, I'm not gonna make a political
GOP.
Yeah, and then I'm not gonna get political in this context. But one thing that really struck me, even during the vice presidential debate, I've never seen two men in a political debate spend that long talking about like childcare and women and families and caregiving. I was like, wow, this segment is kind of going on forever, and I'm here for it. But so point being, I think at least these issues are in the conversation, and that feels good, and you guys are here, and that feels good. So everyone give themselves a round of applause.